as we kind of, before we came on the air, as far as talking about, we call it the first 5 minutes. So all we train in is the first 5 minutes over and over and over again. So our people get that muscle memory, and they get the muscle memory of, we even call it different tier level bags. So we call our first in bags to a full arrest are actually our Eligard airway bag, and then the monitor and suction and oxygen. And as you'll notice, we don't have Lucas there yet, and we also don't have a med bag there yet. And the reason why is, I think evidence-based medicine has shown, one, if we can get bystander CPR, that'd be fantastic.
Of course, right.
And then also even AEDs on the patient, which would be ultra fantastic. But once our people get there, really to focus on the CAB, so compressions, then airway, breathing. And again, we all know, epinephrine now, that's its own podcast.
That's probably so.
Is epinephrine great, or is it the work of the devil, or you never know. Right. So the pendulum is swinging all over. I get better hearts, but I'm killing brain. So that's its own talk.
Every drug in there is up for debate.
Correct.
Yeah, or as I call it, medical holy water at that point. So
not inappropriately.
So I tried to tell our people, hey, if you carry a med bag in, then you're going to be focused on the med bag.
Meds, of course, yeah.
And if you bring Lucas in, you're going to be focused on, I want Lucas right away, because they love fire medic Lucas. And I said, well, if you're going to do heads-up CPR, though, you have to do at least a round or two of rescue CPR. So again, Lucas isn't as critical. Obviously, in the initial part of a full arrest, epinephrine in the rest isn't as critical, even in asystole or PEA. They found by doing the heads-up CPR process, in fact, this is from Dr. Pepe, so he would have to comment on it, but he had made the comment that as much as defibrillation was to VFib, he likes rescue CPR, heads-up CPR to asystole. So he felt, what do we really have to offer these people in asystole? It's epi and treatable causes, which usually you can't find much anything.
Sure.
So he really, at least from his talks, really liked this whole process. So again, it's not just heads-up CPR, it's a bundle. Now, can I tell you what part of that bundle does it? No, because it's a bundle. I mean, you really do have to do rescue pump, rescue CPR, impedance threshold device, maximize flow. What angle am I going to put these people in? How am I going to do this? At what point do I deploy it? So there's a lot to that process. Right. So it's not just, I'm elevating the head.
That's always the troublesome part in any cardiac arrest.
Right.
Is understanding what roles any particular intervention plays. Right. And I think we found over and over and over, it's not one single thing. It's combination therapy that ultimately leads to the outcomes. Right.
And then I did look at our numbers. They're very, very small. And like I said, the nice thing is we do the quarterly meetings, so they get our numbers, but we can hear from other people throughout the country, and then load in their numbers to our numbers, et cetera. But I saw ours, like most people, probably around anywhere from 8 to 12% resuscitation, and all of a sudden we were getting, upper teens easily. Then all of a sudden, sometimes in a 6-month block, we would even get upwards of 28% resuscitation. Our numbers are small, so I would hit a stretch of asystole elderly patients where it probably isn't going to be working as great. But we definitely took us from 8 to 12%, peaked at about 28%. Now and we have all comers. I even brought my numbers, but we have all comers that a majority of our full arrests are still age 70 or greater.
Understandably so. Right?
Unfortunately for us, half of our full arrests are asystole, which I wish it was more VFib or a truly
something
viable,
you can work, right?
Something I can work with. But even with that, we still are at anywhere between 18 to 28%, where before we were anywhere between 8 and 12%. And like I said, do I think it's just heads-up CPR? Absolutely not. Absolutely not. It's the bundle.
Yeah. And you also don't think it's not because you're spending so much more time practicing CPR in general?
I think, I'll tell you, and that's an interesting question, because when I instituted rescue pump, And we had the ITDs already, impedance threshold device rescue pod. But once I introduced rescue pump, I don't know if you've ever done it. I've done it, obviously, because with our department and working with the personnel, I'll tell you what, it kicked my butt.
Correct.
Now, I'm old, fat, and gray. People can't see that, I guess, on a podcast. But
we're on video. So
well.
So wave high.
Well, see, the camera gained 20 pounds.
No. These apparently make people skinnier.
Hopefully. There you go. Oh, hold up. Yeah, I love that.
We paid extra for these cameras.
I am gonna have an extra
And
piece of cake
these
then.
headsets make us sound sexier.
Forget it.
So we bought the whole package here.
This is my new
home. No expense spared.
But so when I instituted that, as you mentioned, like maybe part of it is that we're really focused more on muscle memory, really hitting the highlights of the disease, and I'm sure that is part of it. Like I said, it's not just raising the head because. As I mentioned, you do rescue CPR properly, and it's
exhausting.
At least to me, I only can do it for a minute, and then I got to switch out.
Let's talk a little bit about that because maybe not everybody, in the audience has necessarily been exposed to it. Not everybody in the UH system has participated in that, and as it turns out, we are finding out we have national and international audience, right?
We do,
and international, yeah. So.
Love it.
So the basically the concept with the rescue pump. Let's start.
Okay.
Let's start there. What's the working theory there, and what are we trying to accomplish? I've got that up on the screen, Marco, as he's narrating a little bit of this. Will you cut to that?
So the main thing with CPR is, as we said before, everyone kept thinking, "Oh, I'm doing compression, so I'm pushing blood through the body," and it's absolutely not. It really you're sucking blood through the body. So everything was negative pressure, negative pressure, negative pressure. The more negative pressure I can generate, the better. So we added on the impedance threshold device, which I know some studies said, maybe it's not the greatest thing, maybe it is, we're not quite sure. But the impedance threshold device and the rescue pod on the airway, even though it's on an airway device, I emphasize to people it's a circulation device.
It's a circulation device, yep.
So again, if you get a pulse back, take it off.
Correct.
But it's a circulation device that just happens to live on an airway circuit. So that's how we looked at it. Yeah. So then the impedance threshold device allowed us to generate better negative pressure. So again, we got what we felt was better flow with standard CPR. Then when I looked into it further, I kind of told people, again, thinking outside the box, I said, you know what? I said, when you do CPR compressions, the truth is, the only reason you're really pushing down is because you want the up phase.
You need to come up, correct.
Right. So I said, it's really not the compression that's doing this. It's the up phase.
And which is another reason AHA pushes so hardly that you allow complete recoil.
Right. Don't lean on the chest. No kneading dough. Exactly. Because in the end, you aren't really, the theory to me is I'm only pushing down because I want the up phase.
Because you want the up phase.
Well, then rescue pump or the toilet plunger came in. From way back when, and then finally started to get more press. And basically, not only am I doing compression and then having standard recoil, but I'm actually doing active
pulling up,
recoil or decompression. So that's why rescue pump's considered active compression, decompression CPR. And literally on the device, it shows you how much pounds of pressure you're pushing down on, but it also shows you how much pounds of pressure you're pulling up on. So,
which is also one of the beautiful parts about Lucas is that it's doing just that as well with the suction cup.
Yeah, it's kind of I hate to say it's kind of begging the question a little bit. Lucas will never tell you that their suction cup literally does that.
They can't. All right.
Plus, I'll tell you the truth, because I think Stryker has Lucas now.
Yep.
They actually can have it where there's a better delay at the top, which gives you a little bit better upstroke. So they reprogrammed them. At least I think Lucas 3. I know one has the green top, one has the gray top, and so the more
we have a Lucas in here, do we?
We don't know.
The more advanced versions now they can actually reprogram it.
Stryker, take the hint. We don't have a Lucas here to talk about your products. So.
Need fire medic Lucas here.
Yeah.
So they reprogram it so you do get a little bit better of that. So that actually helped also. And like I said, then with the rescue pump though, and going full circle as we mentioned before, when I introduced it, I thought, oh boy, what do firemen hate the way things are and change? So I'm like, how do I thread that needle? So
Well, and then take CPR and make it harder.
right, like I said. So I thought, oh boy, I'm teaching them drill the humerus now, so you get better flow in the leg. Now we're doing this now, and they're like, Jesus, what's Campensa up to this time, right? So then when I introduced that, I had to train them in that, and I'm thinking, oh, this is just another thing.
Right, here we go. Right.
Yeah, once I get to the station, or as I call it, 8th grade for adults, it's gonna be, they're gonna be all over me.
That was perfectly
Right?
timed. You almost
There
got
we go.
you almost got to see coffee come out of Caleb's nose.
Executed over there. So,
Well timed, sir.
so then we did all that, and all of a sudden I'm doing my shifts, at the station with the guys, and they're coming up to me going, "Hey, you know that rescue pump?" And I'm like, "Oh God,
Here it
comes." And they're like, "Oh,
There's something to
that's
that."
pretty cool."
Yeah.
And I'm like, "Oh, okay." I go, "Well, what do you mean by cool? What's so cool about it? I know what I wanted it for."
Right.
And they said, no, honestly, since we've been doing that rescue CPR with the pump and the ITD, not just heads up, but just the
Correct.
pump with ITD, they go, honestly, we actually feel like we're doing something. Instead of just pushing and, asystole or VFib, now it's asystole. They said, we actually, and like I said, and then they noticed empirically,
Of
not
course.
scientifically,
Sure.
that we were getting more ROSC and the like. So they came back to me and said, we're starting more hearts lately.
Yeah, this is intriguing, right?
And when we do it, we actually see changes in the patients, physiology, skin color, skin perfusion. So long story short, they actually
They bought into it, yeah.
Yeah, they actually came up to me and said, "Oh no, we like this thing." And I'm like, "Okay, that's actually great, because then I'll just leave it at that."
Right.
So,
Exactly.
I mean, Fire Medic Lucas was yeah. we love
And
Fire
you
Medic
eventually
Lucas.
transitioned to that, right?
Right. So, and then, yes, but you initially do the rescue CPR, and then the thing is, on the Eligard device, there's a timer, and actually, the reason there's a timer on it, it actually times out 2 minutes. It can go further than that, but the reason you hit the timer is because you never want to elevate the head until you do at least 2 minutes of rescue CPR first. So our personnel, in part of their first 5 minutes when they get there, they're already jumping into rescue pump, getting airway in so they can use the ITD to maximize negative pressure and maximize that active decompression. So they're already doing some of it.
Sure.
Then once we lower them into the into the Eligard
Eligard,
device, the way they train it, they call it tube timer. Now that the tube's in, ITD's on, you've been doing some rescue CPR, now you hit the timer. The reason you hit the timer is because you do not elevate the head. Don't touch the elevate the head button until that timer gets to 2 minutes. Because now we know you've done at least 2 minutes of good rescue CPR. Now you can hit elevate the head. Now it slowly, in a very controlled, slow fashion, is going to elevate not just the head, neck area, but slightly the upper thorax also. But that's why the timer's there, because it basically forces you to say, no, don't elevate the head yet. Here, we're going to do this first part. And then once that's accomplished, now you can hit the timer and go ahead
Slowly
and
comes
elevate.
up.
Yep. So
And does it pause at the various positions, or does it just
No,
slowly
because-
over time go up to
right,
that 30%?
This one, it has it's a screw device that turns, that actually slowly
Sure, okay.
elevates
Yeah.
it. Like I said, when we had the cot, we had no other choice. Or if you want the Zolban, fine. Zolban, fine. That we had to just slowly go to 15 degrees. Then we would actually wait a minute or two, and then we would slowly elevate a little bit higher, no further than 30 degrees. Again, the Eligard device just made it nice because you hit the button and it does.
Just goes.
It's a no-brainer.
Right,
It does all that for us. And like I said, it's you're adding on another device again with our fire medics, but the minute they saw the now Lucas isn't going to topple over. They were sold.
That's easy, right?
Yeah, and actually, to tell you the truth, it's almost like a very big CPR board. And then when I said, oh, yeah, and this thing, once you hit the button, it'll take care of the rest. You don't have to think it through. Did I elevate the head too much? Not enough. Did I do this? Did I do that? Et cetera. So,
What is the patient population for this? Who's eligible?
Age
yeah,
and weight.
actually, that's a great point, because I've asked that. I said, well, is this approved? Like, if I have a 16-year-old, can I use it? And the adage was, if you fit, you must use it. So that's what we came up with. So long story short, and then how do you determine, well, do they fit or not? Basically, if they can fit with Lucas, which our guys were already used to judging who fits, who doesn't fit.
Sure.
If they fit Lucas, then they'll fit
they'll fit
the
the Eligard.
Eligard device. Now, Eligard will tell you in their literature, if you're above 350 pounds, you may not fit, warning, and all that. But then in discussion with them, I said, well, I got some patients that weigh 480. I mean, we do have patients 480.
Yeah.
But I have some patients that weigh 380, so they're above the technical level, but most of their weight's down below. And really, it's more of, do you fit in the device? And really, the main thing then is, will Lucas click
fit
over
top,
it?
right?
So what happened with our people was, already in our protocol, if you could use Lucas, which you can certainly in a teenage age group, you could use Lucas.
Mm-hmm.
So right away we were, hey, again, like I said, it was kind of
And the same would apply to trauma patients.
No. You could, but this would be
Because
medical
Lucas is
resuscitation.
contraindicated for us for traumatic arrest,
Right.
but just trauma patients
We
in
don't.
general.
Yeah, we don't.
Okay.
Nope, just medical. Yep. And again, like I said, kind of tongue in cheek, but if you fit, you must use it. So our guys were used to, if Lucas would fit, fine, and then we know we can use the Eligard or vice versa.
If it fit, it ships.
And so again, just because you're, they'll, if you read their literature though, in their insert, it'll say, well, is this for 18 and above? But then they kind of beg the question a little bit, saying, well, just because you're, 17 and 6 months old, if, there's
But yeah, you're
17-year-olds.
physiologically adult, right? Yeah.
Then, why would I not let them do it? Actually, the kind of tongue in cheek also, what happened was the other studies were pig studies, and they showed better resuscitation of these smaller sized pigs. So I said, well, if the pigs are surviving a lot better, then why would I deny a 16-year-old this device? If in my heart, I know physiologically it probably is going to have a better outcome.
Sure.
So then that's when they said, oh, yes, you're okay. But again, it's more of, if you fit, you must use it. And that's how we kind of determined it. So I don't know if that. Plus, there's a lot of other scenarios we had to go through that I worked on with Dr. Lurie, and we kind of picked each other's brains as far as, okay, so you go in on a full arrest, not everyone's on the floor. What happens if it's a nursing home or extended care facility and they're in a bed? Mm-hmm. And to me, the only way to do good CPR in a bed is mechanical. We all jump up there and put a CPR board, and then the whole bed's flopping up and down. So, and we ran through all those different scenarios and said, well, maybe you really can't do good rescue pump in the bed. Maybe it is better to at least get start with the pump and that, but get Lucas on as soon as possible. So we went through scenarios of patients found in a bed. I even went through scenarios of, resuscitating the patient. I've done the whole thing, and oh my gosh, I got them resuscitated, so I'm going to pop off the rescue pod,
Right.
and I'm going to leave their head in a head-up position, no big deal, because now their own heart's beating, etc. They went back into full
coded
arrest
again. Sure. Yep.
So now what do I do? So at that point, actually, it's recommended in our protocol, we hit the down button then, and the device just drops itself back down to neutral, and then we let Lucas do 2 minutes of CPR because we hit the timer again, and then we re-hit heads up going back up again.
Oh, okay.
So we went through all the scenarios of, I went through the process, resuscitated, now I lost resuscitation, should I lower the head? Yes. here's how we go through that process. Okay, I initially get there and the patient's in a bed, so how am I really going to do rescue pump, and what am I going to do with these? So we kind of storyboarded a fair number of scenarios to try to think all that through to give the personnel guidance with each of those. Like I said, they know if they go to an extended care facility or a nursing home. I mentioned before that the Eligard airway bag and the monitor suction and oxygen are first in. Well, they know if they go to a place like that, that Lucas is one of the first in bags
Yeah.
also.
A known exception. Yeah.
Just because, obviously, like I said, there's a good bet you're going to find them in a bed. And so we storyboarded all that. Now, I'll admit, again, it's a process. It was growing pains. I had to get feedback from the guys as far as, what's
Practicality.
working, not working. Should I keep the rescue pump in the bag, not in the bag? Should I change this around? And so we had kind of those growing pains with what worked better, not worked better, and kind of got to the point we are at now.
And if you had a bariatric that didn't fit the Lucas, which means,
And
of
we've
course,
had.
that I'm sure you have, right?
Yeah.
Hence the question.
Continue your manual pump CPR and raise the
and
hood.
you had, you did not have, then of course not use the Eligard. Would you?
Or we had some where they tried to use the Lucas, didn't really fit. Patient was already in the Eligard, and they actually went ahead. I'll be honest with you, they're great. They went ahead and did rescue pump CPR the whole way in, switching in and out with each.
That was really my question. Is you'd still?
Yeah,
they're still in the habit of.
They fought through it and they liked that. So I was kind of like, wow. How did you guys, like I said, there's times I just ask them, how did you guys really handle that? Again, MD, not GOD. Let me know what works, doesn't. Yeah. And they were like, no, we went ahead and just kept switching in and out. And
that's all you can do, right?
Rescue pump the whole way in and all that. So I was actually impressed.
That's fabulous.
So they kind of battled through it. But like I said, we tried to storyboard as much as we could. And then again, like I said, with this process and the different people you're going to encounter, and like I said, we still do our information back and forth with Dr. Lurie. Also, we even joined I think it's Advanced Cardiac Resuscitation Group, which is the group that Chief Powell, now that he's retired, is active with. We stay in touch with them, so we still try to share our data with all of them, look at their data. Share ideas back and forth of what we think is, gonna work, not work, would help, not help, etc. So again, we're still always trying to learn from it. But I mean, definitely the numbers were encouraging. I can say that. So
I actually want to ask a dumb question. But I'll start with a statement, of course. My dumb statement.
Dumb statement leading into a dumb question?
Yeah, exactly. So we alluded that we've now found out we have international listers. We have people of all practice levels. Green's a professional, full-time
paramedic, right?
Paramedic, fire department. And if we look at AHA Chain of Life, which I had to look up, not that I haven't, because I don't have it memorized.
Well, the chain keeps growing, too.
It's true. 26 links now.
Yeah.
First one's essentially call 911, right? And then the first real step after that is high quality CPR that anyone can do, whether you're trained CPR or just a layman. When we talk about that, we know that the patients that have the best outcome are going to be the ones that have that high quality CPR right away. That's bystander, right? Witness arrest. Someone's there that knows CPR, and they're the one that gets CPR. Yep. Right. And then after that's defib, early defibrillation. Right. And then the next one is advanced resuscitation, which is what this is.
Right.
It's our drugs too that we made mention to and kind of made fun of.
And augmenting
what the resuscitation
all
is.
of the
yeah, but that's further on down the line. It's really CPR. Like witness arrest, CPR, early defib if possible. We have AED. And those are basic skills.
Yeah.
I mean, not even basic skills. Those are layman skills that you can get trained on. Sure. Now, that leads to my dumb question. If we have a basic that has a rescue pod, can they use that rescue pod on a supraglottic airway?
Yes.
So they can use
Yes.
the
And-
rescue pump. They can use the rescue pod. They can
Yes.
put their supraglottic airway in. This is basic skill
Yes.
stuff.
Can
And in
defibrillate.
fact, believe it or not, even though we're a full
defibrillate using
paramedic,
Lucas.
even though we're a full paramedic department, we initially, not again endorsing any product, but we actually start with the eye gel because even though our guys have McGrath, scopes, tube, everything else, because we wanted to expedite the process, we actually tube timer. We actually slide in the eye gel and attach the rescue pod immediately, so we can use the rescue pump and then do appropriate rescue CPR ASAP.
Yep.
So
I tell my squads the same thing. Is like,
Yep.
if you want to intubate, if you're an expert, that is your thing,
Right.
and you're an expert, and you can get that tube in first right away, and
Right.
great. If not, and you're busy and you have nothing else to do,
Right.
supraglottic and move on.
But yeah,
you've got a lot to do.
The basic people can. Eye
But the
gel,
basic people can
use
always
rescue
use it.
pod, can use rescue pump, do good rescue CPR,
Defibrillate.
defibrillate, yeah, with the AED and that. So, oh yeah, no, that all can be. And,
Do you get
and really
odd-
evidence-based medicine, like you said.
Correct.